Good day, everyone, and welcome to Nova Biomedical Veterinary Education Events. Today we will have the following topic: red, hot, and inflamed, recognizing and diagnosing SIRS and sepsis in small animals. My name is Federico Montealegre-Golcher. I'm a veterinarian and an immunologist. Currently, I serve as a Director for Medical Affairs in Nova Biomedical. Today, our featured speaker is Dr. Deborah Silverstein. She is an associate professor at the Department of Clinical Studies at the University of Pennsylvania School of Veterinary Medicine. Dr. Silverstein received her critical care degree at the University of Pennsylvania. Her DVM is from the University of Georgia, where she also completed a rotating and small animal internship before her residency in small animal emergency and critical care at the University of California in Davis. Her research interests include the diagnosis and treatment of various shock states, including sepsis, and changes in the microcirculation of critically ill patients. She co-edited a textbook, Small Animal Critical Care Medicine, and just finished serving the Vice President and Scientific Chair of the American College of Veterinary Emergency and Critical Care. Her webinar has been approved for RACE Continuing Education credits. After the webinar, you will receive an email with a program survey link. After completing the survey, follow the link to download the Continuous Education certificate. There will be a question and answer session after the live webinar. Please type questions in the Q&A box located into your screen. Thank you very much.
Thank you very much, Federico, for the kind introduction. It's a pleasure to be here this evening with all of the listeners, where we're hopefully going to be learning a lot about a really important and fairly common disease that we see in small animals, which is SIRS and sepsis, and recognizing and diagnosing patients that might be suffering from this particular disease. So I'd like to start by just going through a quick overview of what I hope to review in the next 50 minutes. We're going to start first with the terminology that is the basis of defining SIRS, sepsis, MODS, and other abbreviations in veterinary medicine. We'll then talk about Sepsis 3, which was released last year and is the basis for the changes that have occurred in human medicine with the transition from the SIRS criteria to a new definition of sepsis. Between SIRS and Sepsis 3 was a second definition called PYRO, which I think deserves some attention because it has a lot of important information about the hows and whys and potentially the future of how we might better define SIRS and sepsis in small animal patients. And then we'll get to the meat of this talk, which is really trying to identify patients that are suffering from SIRS or sepsis by looking very closely at their history, their clinical signs, and then what we can do as veterinarians to diagnose SIRS or sepsis and to help keep our suspicion appropriately high and to come to a timely diagnosis in hopes of maximizing the outcome for our patients. To start with the terminology, bacteremia is something that we've all experienced even as frequently as when we get our teeth cleaned. It basically just means the presence of viable bacteria in the bloodstream. It's something that most people or animals can deal with quite easily with our immune systems, and it generally does not lead to serious disease. Infection is the inflammatory response, the presence of organisms in the body or the invasion of a normally sterile tissue by pathogenic organisms. And even an infection by itself is not going to lead to any severe derangements of the body unless it progresses to a more systemic inflammatory response type syndrome. And that's what SIRS is. This is really the clinical manifestation of inflammation and the response to an underlying injury or infection due to either an infectious or a non-infectious insult. And this has generally and traditionally been defined in human and veterinary medicine as a change in either respiratory rate or the partial pressure of arterial carbon dioxide, a derangement in heart rate or temperature, as well as changes in the white blood cell count that indicate a systemic response to an underlying insult or infection. So here we have a table that is more specifically defining the criteria that we traditionally have used to categorize a dog or a cat with systemic inflammatory response syndrome. Generally in dogs, we require that there's 2 out of 4 criteria present, or in cats, 3 out of 4 criteria present in order to say that they are suffering from SIRS. And you can see the parameters that have been published in a variety of different studies for both dogs and cats, which have specific cutoffs for temperature, either increases or decreases in rectal temperature, changes in heart rate with tachycardia, or more commonly in cats, also bradycardia, and also changes in respiratory rate, which generally are defined by tachypnea, most commonly greater than 40 breaths per minute, but a couple of definitions are greater than 20. And then changes in the white blood cell count on CBC, which we will talk about a little bit more in detail later, which is going to either be an increase in the white blood cell count, a decrease in the white blood cell count, potentially indicating that the demand is greater than the supply, and then any evidence of immature neutrophils, such as an increase in the percentage of bands or potentially evidence of a toxic left shift. When we think about SIRS and everything that can cause inflammation without infection, on the right in this diagram you can see that there's pancreatitis, trauma, hypoxia, burns, or even heat stroke or other disease processes such as immune-mediated diseases or potentially neoplasia. And then the far left bubble is showing infection, so bacteremia, viremia, parasitemia, fungemia. And although there's overlap between SIRS and infection, sepsis is crossing both of these, where it can be very difficult to determine in any given patient whether or not they are truly septic or potentially just suffering from a non-infectious cause of inflammation or just a simple infection. So in order to better describe sepsis, let's make sure we all understand these definitions. So sepsis is defined as the presence of a systemic inflammatory response syndrome secondary to an underlying pathogenic organism. Severe sepsis, which has commonly been used in human medicine but has recently been phased out, is the presence of sepsis plus evidence of hypoperfusion, organ dysfunction, and or hypotension. And then septic shock is defined as severe sepsis plus hypotension that is refractory to intravascular fluid resuscitation. In the most severe stages of SIRS and sepsis, animals may progress to having organ dysfunction, which is known as MASA. This stands for multiple organ dysfunction syndrome, and it's defined as the presence of 2 or more organs that are no longer working properly or in some way dysfunctional. About what organs might be affected with MASA, this diagram is just pointing specifically to what organs are commonly affected. First is respiratory. So we commonly see a pulmonary capillary leak syndrome secondary to inflammation in patients with SIRS and or sepsis, and this can lead to acute lung injury and acute respiratory distress syndrome. We also can see acute kidney injury. Typically there's tubular insults that lead to an acute rise in creatinine and or oligoanuria. We can also see derangements in the GI tract leading to vomiting and or diarrhea, as well as potentially bacterial translocation from the intestinal tract into the bloodstream. The liver is sometimes affected by SIRS and sepsis, such that the production of coagulation factors, the production of albumin, as well as other hormones in the bloodstream and gluconeogenesis are deranged and lead to systemic sequelae. Cardiovascularly, we may see myocardial dysfunction secondary to sepsis or SIRS, as well as potentially vasodilation that may even be refractory to catecholamines, a syndrome known as vasoplegia. And lastly, there can be hematologic derangements, anemia, potentially the changes in white blood cell counts that we previously mentioned, as well as changes in platelets and other parameters can be deranged in animals that have systemic inflammation and/or infection. Diagram that I think very nicely explains what can happen in animals with SIRS and/or sepsis, where if we start at the left top area, you can see the yellow box. It shows whatever the causative agent is for an animal to develop systemic inflammatory response, whether that's bacteria, trauma, shock, or any other of the diseases that I mentioned earlier. You can see that there's activation of all of the cells in the body, as well as complement and coagulation and acute phase proteins, which are going to increase cytokines and chemokines that are circulating in the blood, lead to an increase in reactive oxygen species production and enzyme release in an attempt to get rid of any offending agents or potentially clean up any traumatized tissue. This is subsequently going to lead to increases in vascular permeability, hopefully bactericidal actions, as well as deleterious disseminated intravascular coagulation, and some of the clinical signs that we might see, including tachypnea, increased rectal temperature, changes in white blood cell count and tachycardia, as well as an increase in peripheral vascular resistance. What we commonly recognize in these patients initially is what we call a hyperdynamic phase of a systemic inflammatory disease, where the animal appears to have an increase in cardiac output, very red and rapid refill of their mucous membranes. They often will have the tachycardia and almost bounding pulses from changes in vascular resistance with a maintained systolic blood pressure, and they may be warm on their extremities as well as the rectal temperature. If, as a veterinarian, we do not identify rapidly that these patients are suffering from a systemic inflammatory response, then the progression of a hyperreactive immune response to a hyporeactive immune response and immunoparalysis can ensue, and this is where we start to see the development of MODS and multiple organ dysfunction that can subsequently be recognized by edema, tissue damage, organ failure. Now the white cell count is dropping and the demand is exceeding the supply, shutdown of the immune system as a whole, and increased susceptibility to infection. Very often when we see patients in the clinic, it's hard to know where they are in this continuum of the inflammatory response, and that's probably why we struggle to come up with a panacea treatment for these patients, because it really depends on whether it is the inflammatory response that's leading to self-destruction, or whether it's actually the organism or insulting agent that is causing the body to shut down. And the treatment of these two conditions is obviously very different. If we look specifically at the potential shortcomings of the current SIRS and sepsis criteria, we can see that the SIRS criterion septic dogs has a very high sensitivity and a fairly low specificity, which means that if we have a patient who does not fulfill the SIRS criteria, it's very unlikely that it's going to be a false positive. The problem is if we have a dog that is playing Frisbee on a hot afternoon and presents to our clinic with maybe one episode of vomiting or shaking, they may actually meet the SIRS criteria but not be sick. They may not be a patient who we really have to worry about progressing to MODS or potentially requiring a full workup. So we're going to probably overdiagnose disease using these criteria, but the way that some people look at this is it's better to make sure we don't miss disease if it's not there than to miss it if it is there. So we have found in this study that was done by Hopsom et al. In '97 that there is an overdiagnosis of sepsis in non-septic patients of about 36%. So the further studies that have been done in human medicine, this is one that was published in 2015 in the New England Journal of Medicine. This study was looking at the utility of the SIRS criteria to identify severe sepsis using data from over 1 million people over 14 years in New Zealand and Australia. And what they found is that almost 90% of the people that had SIRS were actually septic. But there were also a portion of people that actually didn't have SIRS that met the criteria for sepsis and eventually ended up with organ dysfunction and a high mortality rate. They also found that the SIRS-positive patients tended to be younger, more severely ill, had a higher mortality, more organ failure, and that this meant that 1 out of 8 of the patients that didn't meet the SIRS criteria were not suspected of having sepsis. So there seems to be problems both in overdiagnosing sepsis potentially, as well as missing sepsis in some of the patients that may truly need our attention. If it how common sepsis and potentially SIRS is in small animals, we'll start with dogs, looking at an abstract that was presented at DACVEC in 2007, looking at the epidemiology of canine sepsis in a teaching hospital. And they found that about 4% of dogs that presented to their hospital and were admitted to the hospital actually had a diagnosis of sepsis on admission. And furthermore, almost 2% actually developed sepsis and signs of sepsis in the hospital. And why it's important that we actually recognize this is because there's actually a 55% mortality in the patients that are identified as septic compared to about 12% in the control group. So we want to identify these patients rapidly to try and minimize this mortality. The septic dogs also had a greater length of hospitalization. They had more days in the ICU and subsequently a greater bill at the end of their hospital stay. What about cats? Is this a problem in cats? Do we need to worry about cats? Well, this was a study that was published in JAVMA in 2016, where the authors looked at the epidemiology of SIRS and sepsis in cats that were hospitalized in a teaching hospital. And they looked at 246 client-owned cats that had a total of 275 admissions over 3 months. And they found just over 6% of the cats actually did meet the criteria for diagnosing sepsis on admission. There were 16 that just had an infection but not evidence of SIRS, 81 of these cats that had SIRS but not evidence of sepsis, and 161 that did not have any of the criteria necessary to diagnose SIRS. And I should have mentioned earlier that we generally diagnose it SIRS if there's 2 out of the 4 criteria we mentioned in dogs or 3 out of the 4 in cats. In this study, 4 of the cats developed sepsis while they were hospitalized. So again, more than 1%, so about 1.5 out of every 100 cats that are in the hospital develop sepsis. And that's a fairly significant number. We don't want to miss that cat and potentially see higher mortality rates in those particular patients. 7 out of 21 of the septic cats died or were euthanized, so there was a 33.3% mortality rate in cats that were diagnosed as septic. So let's just look for a second at how this might apply to a patient that you are seeing in your hospital. Let's say we are meeting Patrick, who is a 6-year-old male castrated Rhodesian Ridgeback that has no past medical history, is up to date on vaccines, and has good parasite control. Patrick got into the trash 2 days ago after a party and presents to you after vomiting 2 nights ago and becoming anorexic. There's been no change in his drinking, urination, and he's had no bowel movements that the owners have noticed. But on your physical examination, you notice that he is depressed but responsive. He's about 6 to 8% dehydrated. His mucous membranes are red with a capillary refill time of about 0.5 seconds. He has a temperature of 103 degrees Fahrenheit. His heart rate is 160 with synchronous bounding femoral pulses. His respiratory rate is 28, and he has cranial abdominal pain and vomits bile after you palpate his abdomen, and then proceeds to have mucus-filled diarrhea. So the big question we have is Patrick septic? He did meet the criteria that we mentioned for SIRS, but is he truly septic? Well, we know that if we use the veterinary approach, 2 out of 4 of the SIRS criteria have been met, and therefore we would suspect sepsis. But as we mentioned, there are going to be some animals that are actually overdiagnosed with this particular criteria. And so when we finally got the diagnosis in Patrick, we realized that he actually had pancreatitis. Had we started him on broad-spectrum antibiotics and searched for sepsis and started culturing a lot of his body fluids, that might have led to unnecessary diagnostics. And so this has recently been realized in human medicine. And so there's been an attempt to try and change the definitions, which I think may soon happen in veterinary medicine, although they haven't happened yet. But I wanted to talk a bit about, again, why is it important that we try to recognize this overlap of infection and sepsis and SIRS and see if we can identify which patients are just responding to inflammation as opposed to which patients are actually suffering from an overwhelming infection that requires treatment. So the definitions have been changed recently in human medicine. They were published in 2016 with the new Sepsis 3 guidelines because the SIRS criteria are just too sensitive. We overdiagnose SIRS. We may even miss some patients with these criteria, and they just lack specificity. So the goal was to determine the role of infection in the pathogenesis of SIRS and to try and determine whether the morbidity seen in a given population is due to the infection or the response to either an infection or another type of non-infectious insult. So we really need better screening parameters for infection. So the Sepsis 3 guidelines that are now used in people define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And if you might notice, this is how we actually defined severe sepsis originally. That was the original definitions that are still used in veterinary medicine, but now it's just defining sepsis. So it's trying to rule out patients that might have a simple infection or some other cause of inflammation that's not as serious. And in people, they define organ function as corresponding with an acute change in a total full organ failure assessment score of more than or equal to 2 points. And the full use requires a lot of different parameters that we don't always have readily in small animals or in people, looking at platelet count, bilirubin, a Glasgow coma score, which is assessing their neurologic status, brainstem reflexes, and motor activity, as well as their pulmonary function and mechanical ventilation status. And the full SOFA, as you can tell, is going to be quite high maintenance for us to do in veterinary medicine. But in human medicine, there's a very strong correlation between the SOFA score and an increase in the SOFA score and mortality in people. What Sepsis 3 attempted to do is to take almost 20 experts in the human field and create a very quick SOFA score to rapidly identify patients that should be further worked up for possible infection. And here's what they found is that if a person has 2 out of 3 of the following variables, then you should suspect infection, or a nurse should let a clinician know that this patient meets the criteria for the quick SOFA scoring. And it's a Glasgow coma score less than 15, a respiratory rate greater than 22, or a systolic blood pressure less than or equal to 100. And if a patient has 2 or more of these, then they should be worked up for sepsis immediately. What other models could we potentially consider in veterinary medicine? I think it's good to entertain the possibility that Sepsis 3 might be helpful for us to look at in patients that we are presented with. But the truth of the matter is doing a Glasgow coma score in a lot of our patients is not always fruitful because they all have some degree of mental obtundation if they're very sick. Respiratory rate greater than 22 may or may not be accurate for us. And we have our own blood pressure normals that we commonly use. But these are all parameters that are very easily accessible. In 2001, the human criticalists got together and tried to look at another way of defining sepsis. And I think from a veterinary point of view, this might actually be something that we want to think about as we move forward in defining sepsis, and that is PURE. And this stands for predisposition, infection, response, and organ dysfunction. Again, with the question, is the morbidity due to infection or is it due to the response to an infection or inflammation? Is it the self that's causing the problem or is it the infection causing the problem? And the way that this is looked at is predisposition. Currently, we look at, is there any concurrent illness? Is this a breed that might be more likely to get parvo, like a Rottweiler puppy? Is it an age, sex, or other signalement change that may predispose that patient to being immunosuppressed or developing sepsis? And in the future, we may even have genetic markers that we can use to try and better help us determine the risk analysis for a patient developing sepsis. In addition, we currently use culture and sensitivity of any type of fluid in the body to diagnose infection. In the future, and potentially even in current research, we're assaying microbial products to try and determine if there's bacteria in places that there shouldn't be. And this study, I think, describes that quite well, how we might move forward in trying to use microbial products to diagnose septic effusions. This was a study by Levy et al., where they actually took 25 dogs that had cytologic diagnosis of septic peritonitis, and they did a culture and sensitivity in a microbiology lab, as well as real-time PCR array of microbial DNA. They detected bacteria by both methods in 21 out of 25 dogs, and the identification of bacteria via culture and PCR were identical in 9 of 25 cases. The PCR did identify more positive cultures in 12 out of 25 cases than did the culture method. And it took about 3 hours and 47 minutes to get the PCR results versus 4.1 days and 7.6 days to get aerobic and anaerobic results respectively. So I think we still need to do more research with this, but I think it does beg the question that we may have better methods for diagnosing infection on the horizon, potentially ones that can be done bedside, and using point-of-care machines that are developing every day for use in veterinary medicine. In addition to the predisposition and insult or infection, the response to that infection or insult is what we currently identify with meeting the criteria for SIRS, or other signs of sepsis or shock that would suggest decreased perfusion on our physical exam. In the future, we'll actually do more of an inflammatory response panel, looking at cytokines or specific detection of target therapies like protein C, tumor necrosis, or platelet activating factor to try and figure out how we can best treat a given patient with evidence of systemic inflammatory response. And then the organ dysfunction can also be assessed. How many organs are deranged? In people, they use the SOFA score, as we mentioned. We currently look for 2 or more organs that might be deranged, and I'll show you a study in just a minute. But in the future, we may actually be able to look at cellular responses to an insult that might indicate on a more cellular basis that there's apoptosis or some degree of cellular injury or stress. In terms of how organ dysfunction affects animals that we see with SIRS, this multi-institutional study that was published in 2010, looking at 114 dogs that suffered from sepsis. These were dogs that had more than or equal to 1 organ dysfunction in 78% of the dogs, and 50% of the dogs had 2 or more organs that were dysfunctional. And what was found is that the mortality rate increased as the number of dysfunctional organ systems increased. This seems intuitive, but I think it did deserve being proven from a statistical basis. And the mortality rate in the dogs that had 2 or more organs that were dysfunctional was 70%, as opposed to dogs that had 1 organ or less being at 25%. So every organ that fails means a greater incidence of mortality. So I think this study shows us we want to identify before they have organ dysfunction. Using the PIRO score that we just mentioned in people, this was a study that was published in 2015. They put points on each of the PIRO categories, and obviously as they get more and more of those PIRO abnormalities, the mortality rate would increase substantially. So again, regardless of what type of categorization that we use, whether it's the traditional SIRS classification system that I mentioned in the beginning, whether we move towards more definitions closer to the sepsis 3 in people, or whether we maybe even reevaluate the PIRO scoring system that's been around a little bit longer. I think for now we're going to talk about what we've traditionally used, The question is, what is that system that we currently use and how are we going to use it? We're going to continue to use what you see here in the old category, which is sepsis is suspected infection plus SIRS. Severe sepsis is sepsis plus hypotension, hypoxia, or some other marker of organ dysfunction. And septic shock is sepsis with hypotension despite adequate volume resuscitation. And then on the right, what I briefly summarized is the human definitions for sepsis 3, except you see that they've taken out SIRS, they've taken out severe sepsis, and they've made the definition for sepsis a little more stringent. So let's go look at how we're going to really diagnose sepsis and SIRS in dogs and cats, because we know that this does happen with fair frequency, and we know that there's an increase in length of hospitalization as well as a higher mortality rate in patients that we can identify as being septic. And if we can treat them as soon as possible, hopefully we can learn how to maximize outcome. So first we're going to start with the signalment and history. We know that animals that are very old or very young may be immunocompromised and require a little closer attention and more aggressive supportive care from the get-go. We want to look at current medications that might include things like corticosteroids, chemotherapeutics, or other medications that would predispose an animal to have immunosuppression. We want to look closely at the history to see if there might be a source that we can identify, whether that's an environmental source with rickettsial disease, whether that's an indoor-outdoor cat that's recently been in a cat fight that was not brought to the veterinarian, or maybe even a recent history of trauma that wasn't fully addressed that might have led to organ damage. We want to try and assess to the best of our ability whether there's any evidence of immunocompromise in the patient. This might be something like endocrine disease, such as Cushing's or diabetes, or any other type of comorbidity that may make a patient at higher risk for developing sepsis. We want to assess the current state of the patients that we're evaluating. Did they just recently have surgery that might have ramped up their inflammatory system? Are they debilitated for some other reason because they've been recovering from spinal surgery? Or have they had indwelling catheters or drains for a period of time that perhaps could have developed a nosocomial infection? Is this a patient that has a history of vomiting that perhaps could have had a silent aspiration that wasn't witnessed? So we want to really thoroughly evaluate the signalment history and state of the patient for any risk factors for an inflammatory or infectious disease. The physical exam can be a great tool. Again, it can over-identify patients with SIRS if they've been running on a hot day, as we mentioned. But again, it's just a flag, a marker that we want to use in conjunction with other clinical signs. If the dog is jumping up on the table and wagging its tail, we're not going to worry as much as a patient that presents with these signs that it appears to be mentally obtunded. So the first thing to recognize is there are important species differences. Although cats do sometimes get the classical hyperdynamic evidence of inflammation with those red mucous membranes and rapid CRT as you see in the dog in this picture, very often they will kind of skip the hyperdynamic phase and they look sick, but they don't ever get that classic red fast CRT bounding pulses phase of hyperdynamic SIRS that we like to identify so that we can prevent them from progressing to that hypodynamic multiple organ dysfunction stage. So cats are a little tricky, and I feel like identifying or at least suspecting sepsis in cats as early as possible is important for trying to maximize their survival. Dogs, horses, as well as people commonly have that very hyperreactive immune response, the very large increase in cytokines that leads to what we identified earlier as the SIRS state. We may look for either a febrile patient or potentially a hypothermic patient as a marker of systemic inflammation and or infection. We again want to identify tachycardia, or commonly in cats we will see bradycardia with a heart rate less than 140. Very often, especially cats, will have abdominal pain, and this is thought to possibly be due to a degree of hypoperfusion to the abdominal viscera. And then tachypnea. This can be due to either some sort of lung damage. Cats often do have cytokine-induced changes in their lungs that can lead to acute lung injury. or it could just be an acidemia secondary to a lactic acidosis or other cause of metabolic disturbances. This is a table that kind of summarizes what we would see in the hyperdynamic phase of SIRS and sepsis, with the bounding pulses, the brick red mucous membranes, the fever, tachycardia, and tachypnea. And then if we don't identify this early stage, or sometimes in cats we don't see it, it will progress to hypotension, hypothermia, pale mucous membranes, and weak pulses. Historical findings that we may get from the owner again might include things like diarrhea, lethargy, loss of appetite, mental depression, vomiting, or a slew of other presenting complaints in animals that just aren't acting like they normally do. Keep in mind, again, this is just meant to be a little comical that cats are always very tricky. They like to hide what's wrong with them, so maintaining an index of suspicion in cats that you can't quite put your finger on what's wrong, but the owner reports that they're just not acting like themselves, they're not jumping on the bed, they're hiding in the closet, should be a reason to look a little further. What other diagnostics can we look for? Well, we want to prevent sepsis in high-risk patients. If we have a dog that presents like this or with any other type of wounds or injuries, we want to do everything in our power to prevent them from becoming infected, and prevention is much easier than treating. A definitive diagnosis is often very difficult. Even in people and children, they found that 20 to 30% of suspected septic patients never get a confirmatory culture, and they never actually find the source. Obviously, they're treated with empiric antibiotics, but they don't actually identify where the infection came from. So we I think, have similar problems in veterinary medicine where we treat without a definitive culture, but it's always better to get a definitive diagnosis if we can. Common foci that we want to focus on when we're looking for sources of sepsis will include the lungs, the pleural space for a pylothorax, genitourinary with a urinary tract infection, pyelonephritis, or potentially pyometra or prostatic infection, the abdominal cavity like septic peritonitis or bacterial translocation into the bloodstream, and then bloodstream infections that could potentially lead to vegetative endocarditis. For the source of infection or inflammation may be very obvious, as in this poor little fella that got in the way of a lawnmower one day. So sometimes they present to you with an obvious source of inflammation or infection, but very often they might present just being depressed, lethargic, and there's not an obvious cause for the inflammation or infection until we do a further workup. So what we're going to do from a laboratory perspective, in a patient that we've done a physical exam, we have a history, and we suspect that we need to do a further laboratory workup and rule out SIRS or sepsis. So a complete blood count, a biochemical profile, a urinalysis, plus or minus coagulation testing is probably indicated in the majority of these patients pending finances. In the immediate stage of our workup, we can do a venous or arterial blood gas, a blood glucose, a lactate, and a blood smear, just to try and better evaluate the acid-base balance, the presence of anaerobic metabolism as evidenced by our lactate, perhaps even the presence of hypo or hyperglycemia, and then looking at a blood smear for evidence of neutrophilia, neutropenia, left shifting, or toxic cells. I know that NOVA has worked very hard to try and advance some of the point of care testing that's available for us to do quite quickly in patients suspect inflammatory infectious diseases. The complete blood count can often give us clues for the presence of inflammation and or infection. A leukocytosis or leukopenia we've mentioned, an increased percentage of banned neutrophils or toxic neutrophils, as well as thrombocytopenia secondary to consumption and or decreased production or loss of platelets. Dogs have been shown to frequently present with hemoconcentration, while cats more frequently present with anemia. And then this picture here shows what we could look for in the neutrophils with the Dolly bodies, the cytoplasmic basophilia, as well as vacuolation of the cytoplasm that might suggest the presence of inflammation and or infection. Chemical evaluation, hypoalbuminemia is quite common in both dogs and cats, probably a mixture of vascular hyperpermeability-induced leakage into the interstitium, as well as a decrease in albumin production by the liver, and preferential production and synthesis of acute phase proteins by the liver. In addition, we commonly will see increases in bilirubin, and so these are mild to moderate values that I think people sometimes forget might be due to sepsis. In dogs, it's been shown to be a cytokine-induced bile transport problem that causes cholestasis, whereas in cats, it may be due more to hemolysis from their fragile hemoglobin and the cytokine effects thereupon. But nonetheless, when you see an animal you suspect might be septic and you start to see these changes of a low albumin and a mild to moderately increased bilirubin, it's something that should not be ignored. In addition, an increase in alkaline phosphatase is quite common, and this used to be known as a bit of a triad in conjunction with changes in glucose that we'll talk about. So here are the changes in glucose that we commonly see. We can get a glucose quickly on a point-of-care machine. Hyperglycemia is typically due to an increase in catecholamines, but in the later stages of disease, especially in animals that may have insufficient body stores of fat or glycogen, and more commonly in cats, we will see hypoglycemia due to increased glucose utilization, perhaps decreased gluconeogenesis from hepatic dysfunction and or depleted glycogen stores. One other abnormality that we commonly see in cats and dogs is an ionized hypocalcemia. Anywhere from 25 to even 93% of animals that are critically ill with sepsis may have an ionized hypocalcemia, and it has been shown to correlate with length of hospitalization and mortality. So this is something that we should try to look at on our blood gas machine if at all possible. It's thought to be due to some sort of dysregulation of the parathyroid axis, maybe vitamin D deficiency of critical illness and or a lack of activation of vitamin D or potentially hypomagnesemia. Also want to look closely at the urine. It's an easy fluid to get in the body. We want to look for evidence of acute kidney injury. We want to make sure to culture the urine if there's any chance that they could have a urinary tract infection. It's so easy to get urine and culture it that there's rarely a reason not to in a patient with suspected sepsis. This is showing a picture of a granular cast in the urine, which would indicate acute tubular injury. And we may also want to look for either albuminuria and or an increase in retinal binding protein in the urine and or an increase in the UPC ratio. It's been shown that severe SIRS in dogs is associated with a degree of albumin leak through the glomerulus that's not picked up by the tubules and does go into the urine. And it's been found that almost 70% of dogs with SIRS can have an elevation of the UPC ratio. What about coagulation? Well, we know that animals with systemic inflammation often suffer from disseminated intravascular coagulation. And this is due to a cytokine inflammatory activation of the coagulation cascade and endothelial triggering to expose tissue factor and start the coagulation cascade. So most of the animals with SIRS or sepsis are initially very hypercoagulable, which is hard to diagnose clinically. We did show that if there's a decrease in the PT or PTT on a coagulation profile, that may be suggestive of hypercoagulability. We often are looking for elevations of breakdown products of clots that have been formed in the body, which would be evidenced by an increase in D-dimer, an increase in fibrin or fibrinogen degradation products or FDPs. Potentially, we may see a decrease in the natural anticoagulant in the body, antithrombin and or reduced protein C activity. And then as it progresses and the coagulation factors are used up and these thrombi form in various locations in the microcirculation, the animal will become hypocoagulable. So we want to try and identify patients, if we can, in the hypercoagulable phase. The TEG or thromboelastograph is a machine that is available in some specialized centers and institutions. That's the picture on the bottom left that can sometimes help us to look in vitro for the presence of hypercoagulability, but this isn't a test that is readily available in practice at this point in time. But as the animal progresses with DIC and the factors are used up, they then will go into a more hypocoagulable phase, We can see a progressive decrease in platelet count, a progressive decrease in fibrinogen as it forms into fibrin. We may see continued decreases in antithrombin and protein C and prolongations of the clotting times, the PT and the PTT as time goes on. And this is indicating dysfunction of the coagulation system and the potential for patients to bleed. So we do want to treat this once we identify it. Where else can we look for evidence of infection besides our physical exam, our history, our CDC chemistry, our urine, and our coagulation profile? Well, we want to look at what we mentioned were the body cavities. If there's any chest or abdominal fluid, we want to do some sort of centesis to obtain fluid for cytological analysis, as well as a culture and sensitivity testing. Even if we don't see bugs, especially in the urine, we do want to go ahead and do a culture and sensitivity because sometimes the sample is dilute or we are just not able to adequately see the presence of organisms that are there. Hopefully in the future we'll have ways to better identify bacterial DNA or RNA in samples so that we don't have to wait for the culture, but at this point in time we will probably start treatment pending the culture and sensitivity results. If we suspect that there is pneumonia, obviously we would want to do some sort of endotracheal or transtracheal wash and culture that fluid. It's also really going to help us in trying to determine where else we might need to look, the chest, the abdomen. Quite often we will do an abdominal ultrasound looking for any evidence of fluid-filled structures that might be abscesses or potentially pancreatitis, prostatitis, hepatitis, severe gastroenteritis, or any other abnormalities that may be present. We don't want to forget the bones as a potential source of infection. Discospondylitis is one of those types of infections that likes to really sneak up and not be readily evident. Looking for back pain, neck pain, or any type of ambulation abnormalities on our physical could be a clue. Some animals are very stoic, so spinal radiographs, if we're not finding any other cause for inflammation or infection, may be indicated. And then an echocardiogram, especially if an animal has a recent onset murmur, may be helpful to help us try and identify the presence of a vegetative lesion in the heart. And animals that are febrile are probably especially good for this particular diagnostic. We can also do blood cultures and rickettsial testing in animals that might be suspected of having a vegetative lesion or some degree of endocarditis. And then lastly, we can consider all of the washes and taps that perhaps wouldn't have been done if we found a source earlier. But in animals that are still harboring some sort of inflammatory or infectious disease, we may want to do an endotracheal wash if there's any evidence of pulmonary disease on radiographs, or even more recently, people are looking with ultrasound for evidence of isolated lung disease. Even a CT scan of the chest may be indicated if there's suspicion of abnormalities that are not as easily evident on radiographs. A CSF tap in animals that may be suspected of having meningitis, either septic or non-septic, which may present with just a fever and neck pain. Or animals that are identified as having any degree of joint diffusion, we may want to do a joint tap and evaluate that cytologically as well as do cultures. And again, just looking for areas in the body that may not be immediately obvious, but in animals that we have identified as being probably very inflammatory and having a hyper-reactive response to some underlying insult or infection, it's important to look in all of these places to try and identify the source. Here's a radiograph from a dog that presented with acute GI signs and evidence of systemic inflammatory response, where we found that there was actually severe dilation of multiple loops of bowel. This dog was diagnosed with a mesenteric torsion, an ileocolic intussusception, and eventually went to surgery and actually did well. But had we not readily identified and treated this, there's a good chance this animal would have died. So now to summarize what we've been talking about for the better part of the hour. first of all, the pathophysiology of SIRS and sepsis is very complex, and there's continued research in this area to try and advance our understanding of this disease process. We also know that there are species differences. Cats are their own unique entity, and they often present in ways that are different than other species. We do know that there's a high mortality rate with sepsis and that it's important to maintain an index of suspicion because both at admission as well as in hospital, animals do have a fairly high incidence of SIRS and sepsis. We know that the definitions we currently have are likely to change. Hopefully, with continued research and better understanding of how these diseases can better be identified in patients that present to our hospital, we will have a better and more accurate, more sensitive and more specific way to better use our diagnostic resources and treatment modalities to maximize success. Laboratory testing and additional diagnostics are important in an attempt to find the source of the inflammation or sepsis. Many times it is not immediately obvious what the source is, and so maintaining an index of suspicion and pursuing a stepwise approach to our diagnostic workup is important. A timely recognition is really the key for success. We need to identify these patients very rapidly. We need to make an appropriate, best educated guess as to what might be causing the animal's clinical signs, and then we need to treat them and monitor them appropriately in order to decrease the mortality rate. So in part 2 of this webinar, we will be talking about how to properly treat these patients, how to appropriately monitor them, since we're now experts at identifying patients that may be suffering from SIRS or sepsis. With that, at this point, I would be more than happy to entertain any questions that you might have. Here's a little comic for your enjoyment, and I would like to thank you for your time and attention, and a big thank you to NOVA for this webinar as well. I hope to see you in the second part of this presentation, treatment and monitoring of SIRS and sepsis in small animals. Thank you, and have a good night. Hello, I am currently here live and happy to answer any questions that you might have. I believe I'm able to see them here on the screen if you want to go ahead and type them in. Either everybody is very tired or you don't have any questions at this point. I do feel like usually the treatment inspires more questions, and people often have more inquiries about various approaches to treatment of sepsis and SIRS patients. We will go ahead and wait here for a few minutes to see if any questions arise. I see a question here from Christina, which says, if you suspect SIRS or septicemia, should you do a blood culture right away or focus on finding the source? Well, that's an excellent question, and it actually points out a difference between human and veterinary approaches to patients like this. And that is that in people, blood cultures are done extremely commonly and probably should be done more frequently in veterinary medicine as well. However, there have been some concerns with taking large amounts of blood from some of these patients that are quite sick, and especially the smaller patients. If we're presented with a cat that weighs 3 kilograms, and we ideally want to get at least 2, if not 3, 5 to 10 ml blood samples for culture, it can be a decent blood volume to pull. That being said, I do believe that if your physical exam and initial diagnostics do not immediately identify a source, as you continue to do your further workup, it is a good idea to consider getting a blood culture started. That doesn't mean that you're going to immediately get results, of course. It will take a while, although some of the future diagnostics may help us with getting more rapid detection of bacteria circulating in the bloodstream. But I think that a blood culture is important probably within the first 6 hours of admission, but perhaps looking more specifically for the source, especially since some of these are surgical, and the sooner you can get them to the OR, the better their prognosis. It probably is a good idea to continue with the diagnostic workup we discussed, possibly even an AFAST and a TFAST if you suspect there's fluid in any body cavity, doing a quick ultrasound, and then doing the remainder of the lab work and additional diagnostics. But blood cultures are something that you should think of, especially if it's a patient that's febrile without an obvious source for the apparent inflammation or infection. So thank you very much for that great question. Good, we see more coming in. This is a question from Laura. How far do you estimate are we to get PCR testing in the regular labs? This would make possible to treat our patients even during the visit to the clinic. And the question is it going to be years? And unfortunately, I do think it will be years before this is readily available in a cost-friendly format for us. And the reason is because a lot of these tests actually require that you're testing for specific DNA or RNA. So we really have to know exactly what bacteria you're suspecting in the area that you're culturing. So if it might be abdominal fluid, we'd probably be looking primarily for gram-negatives or enterics. And so that's what the assay would be targeting. But I think the technology is definitely there, and it's a matter of us just getting a little bit more information as to how to best use these diagnostic tests combined with more evidence in clinical patients, and then getting a company that can produce these at an affordable price. But it is an exciting new diagnostic that is being used in some human hospitals already, and I think although we're looking at years, hopefully it's going to be less than 5 years before we can be using these fairly routinely in patients we suspect to have any type of sepsis. Thank you for another great question, Laura. Anyone else with a burning question? Even if you think it's simple, I bet other people have the same question. So please go ahead and ask if you have any questions on your mind. I can always be reached through your NOVA representatives, and they can get you in touch with me via email or other. I'd like to thank everyone for joining us this evening. I hope it was helpful. And again, thank you to NOVA for sponsoring these Helpful C series. Have a good night.